كأنه في صوت هواء، في حدا قاعد بمكان في ويندي.
دكتور صفوان.
دكتور صفوان شكله في هواء
والصفان على البحر. I think we need to check that because it's just make noise.
Yeah, background noise.
اعتقد احنا المفروض كلنا نعمل انميوت احسن، كلنا نعمل ميوت، اسف.
Yeah.
دكتور مازن.
Dr. Mazen, can you hear us?
I think he's disconnected, Dr. Osama. I think you can take over.
Yeah, I think it's a good evening or good afternoon for everyone. And really, we're going to start ocular surface disease session on behalf of Dr. Mazen and Dr. Safwan. Basically, will be the first talk will be Dr. Hussein. It will be dry eye disease. What are we heading for? So, Dr. Hussein, it's nice to have you with us today. And you can share your screen, please.
Sure. In this scientific webinar, scientific conference. You have my PowerPoint, my slides?
Yes, we can see your slides.
Thank you so much. My talk is about the dry eye disease. What are we heading for? I have no any conflict of interest. So as a first point, I want to ask a question: why is the dry eye disease challenging? Well, we know because of the lack of correlation between sign and symptom between the dry eye patients, this disease is a challenging. It's about the complex etiology, limited number of U.S. Food and Drug Administration approved treatment option, and also potential progressive nature of this disease and poor patient company. Because of all of these reasons, dry eye disease is a challenge. And whenever we want to have a good practice in dry eye, we should have a simple and practical definition regarding to the dry eye. And also we should need a straightforward classification, and based on this classification and sub-classification, we can go to the treatment. And because of all of these, we should achieving a differential diagnosis and classification into specification. This is a stage subtype, and go to a directed individual treatment approach. Sorry, I have a problem with. Sorry. I know you know about this lacrimal functional unit. It comprises of ocular surface. It's composed of the cornea, conjunctiva, meibomian gland, and also main and accessory lacrimal glands, and the neural network that connect these components together. And whenever we have the disturbance in any component of this unit, we have a dry eye disease. As another interesting unit is ocular surface microenvironment components, that these environments also have components of lacrimal functional unit, and as well as other components such as some small molecules, vitamins, and also matrix, immune cells, and the microbiome in this microenvironment. And damage to any of these components can create and make a dry eye disease. Let me have a historical overview of definition of dry eye disease. You can, the first diagnosis, the first definition was proposed at 1903 by Schirmer, then by Shubren, and any eye presented the first definition of dry eye at 1995. Dry eye disease is a disorder of the tear film due to tear deficiency or excessive evaporation, which causes damage to the interpupillar ocular surface and is associated with symptom of ocular discomfort. It was a very big, solid beginning for the consensus of dry eye definition. Japanese Society of Dry Eye also presented another definition in 1995, and also again in 2006. And based on this definition, dry eye disease is a chronic disease of the tear fluid and keratoconjunctival epithelium that does result from various factors and accompanies ophthalmic discomfort and abnormal visual function. The diagnostic criteria based on this definition were assessment of symptom and also doing some diagnostic test, and based on the result of this evaluation, they established the definition of dry eye. And this figure shows the Japanese definition about the dry eye, the definite dry eye and probable dry eye based on the result of the evaluation of the symptom and some test of ocular evaluation. And also we have another panel by Delphi panel in 2006, and based on the changes of this compartment lids, tear film, conjunctiva, cornea, and vision, they put the patient in the 4 level of severity. And also dysfunctional tear syndrome panel also introduced another definition and classification, and they put the patient into these 4 categories: aqueous deficient, evaporative, goblet cell deficiency, and exposure-related dysfunctional tear syndrome. And it also shows the ODC European consensus, and also based on the combination of symptom and some ocular tests, they divided the patient in some scenario and some subclassification. And dry eye workshop, that is a collection and meeting of experts in dry eye in the world, presented 2 definitions at 2007 and 2017. And based on the last definition, tear film instability, hyperosmolarity, ocular inflammation damage, and neurosensory abnormality play etiologic roles, and we should consider them whenever we want to evaluate the patient with a dry eye disease. And Asian Dry Eye Society also presented another definition for dry eye based on mentioned that dry eye disease is a multifactorial. All of these definition emphasize on the multifactoriality of the disease of dry eye. And based on this definition, dry eye characterized by unstable tear film causing a variety of symptoms and or visual impairment, potentially accompanied by ocular surface damage. They emphasize only on the combination of symptoms that evaluated by some special questionnaire and also unstable tear film. They introduced the term of short TBUT as a very important variable in dry eye disease. And about the classification, we have also a different classification, NEI classification, Morabi at 2005, based on the etiopathogenesis, they put the patient in this 10 category, and also Delphi classification, dry eye workshop 2007 classification. They divide the dry eye patient into two main categories, aqueous and evaporative, and sub-classify at different groups, such as Sjogren syndrome and non-Sjogren in the aqueous deficient type, and infusing and experiencing evaporative in the evaporative category. And is the last classification that presented by dry eye workshop at 2070, and based on this classification and evaluation of the symptoms and sign, they put the patient in the different classification. Eventually, they put the patient in three categories: aqueous deficient, evaporative, and mixed. And 2/3 of the patient are in the mixed and evaporative category. And it's also an Asian Dry Eye Society classification was presented at 2020, and they put the patient in the three main categories: aqueous deficient, again evaporative, and also decreased wet ability dry eye, that refer to the problems in the mucin layer of the tear film. And about the diagnosis, I only
we had 1 minute more, but Dr. Hussein.
It shows the diagnosis test, a combination of symptoms and some tests and some signs to establish the diagnosis, and divide the patient into the two categories. And we should get all of this information when you want to evaluate the patient with dry eye. Some of these tests can be done by technicians, such as visual acuity, refraction evaluation, and also measurement of tear osmolarity, and also measurement of presence of inflammatory can be evaluated by the technician. And we need some more additional evaluation that was done by clinicians, such as evaluation by histogram.
Dr. Hussein, we ran out of time, by the way.
Sorry. And this shows the pattern of the tear breakup time, line or area pattern in aqueous deficient, random type in lipid deficient, and decreased with spot or dimple pattern and decreased with ability. It's a very important sign for evaluating a patient with dry eye. This figure shows the different patterns of fluorescent staining, horizontal staining, and if we need to do additional assessment, we can use and measure the corneal sensation to corneal topography, especially in patients with decreased vision and variation in his or her vision, and tear film imaging, use of OCT, mammography, interferometry, measurement of some serum antibody biomarker like SSA or SSP, in especially Sjogren patients, and also getting the culture from ocular surface. This shows.
Dr. Hussein, I'm sorry, I need to terminate here a little bit. Sorry for that, because they really were running out of time, okay? Otherwise, there's no time for other speakers.
Okay, okay.
Sorry for that. You can conclude, please, if you want.
Yeah. In conclusion, and based on this evaluation, we have a different approach to a patient. We should treatment of aqueous deficient dry eye with different agent, and also we can use of different modality for treating the patient with evaporative dry eye. And in conclusion, and there are also emerging measurement and emerging treatment for dry eye, such as nasal neurostimulation and also probing of the meibomian gland and neuropathic pain and treatment of centralized pain by using of some special medicine and also nerve block acupuncture. And about the take-home message, following confirmation of a dry eye diagnosis, it should also determine severity and also etiological subtype for getting a good treatment. And in summary, management of dry eye is an art, and we should not obey only from the some guidelines. And in conclusion, customized and personalized therapy targeting the ocular surface microenvironment with aid in complete resolution of dry eye disease.
Thank you very much, Dr. Hussein. Thank you very much. That's comprehensive, but it was too long. Sorry for the time, it's a bit short. I'll leave it to Dr. Mazen to introduce the next speaker. He's back again.
Thank you, Dr. Osama. I'd like to invite the next speaker, who is Dr. Khalid Aish, please, to talk about impact of dry eye disease on epithelial map. Dr. Khalid, the stage is yours.
Thank you very much. Thank you for giving me the opportunity to start this lecture.
You are the best to present this lecture, Dr. Khalid.
I will be talking, Bismillah ar-Rahman ar-Rahim, Bidayatan, I will be talking about the impact of dry eye disease on epithelial mapping. As Dr. Hussein mentioned, there are a lot of classification or a lot of definitions for
we cannot see your screen, Dr. Khalid.
Oops.
Did you share?
Or the Dr. Hussein, he stopped sharing?
Yeah, Dr. Hussein, would you please stop sharing? Yeah, now we can see your screen, Dr. Khalid. Go on, please.
Okay, thank you. As Dr. Hussein mentioned, a lot of definitions of dry eye disease. One of the new definition is under the tear film ocular surface DOS2 report, which defined disease as a multifactorial disease. So this definition implies that the diagnosis of dry eye is a complex one and requires different aspects of the tear film to be assessed using different diagnostic modalities. And one of these diagnostic modalities is the using the scanning of the. I can't forward my. Okay, there is a delay in the procedure. Okay. The impact of dry eye on refractive and cataract patients, it leads to poor vision quality. In the proof study, they mentioned that despite 6.6 visual acuity, 50% of dry eye disease are complaining of blurry vision compared to only 14% of the control. So it can has effect on vision, had effect on corneal topography, can lead to refractive surprises. This subject will be covered by Dr. Ahmed, I think. And also it can prolong the recovery period in post-operative patients. So we will be talking about topography and tomography, epithelial mapping, and the repeatability of the measurements and the effect of dry eye on operations. So in steps in reading topography and tomography, as we all know, we need to look at the Myers, and this step gives us a clue about what is going on. If we find that there are irregular rings or there are broken rings, this is a clue that this patient could have a dry eye disease. Also, if we the second step is to look at the quality of the scans. If we find that the patient is not cooperative, he can't blink or he can't open his eyes, can't fixate well, this might indicate that this patient could have a dry eye disease. Also, if you look at the scans, we can find areas that are missing, that are not covered by the topography. All these are clues of dry eye disease. Also, if we look at the elevation maps, we can find surface irregularities, we can find irregular astigmatism. If we see like this areas of flat spots, another areas of hot spots, this is also another clue of dry eye disease. So it's very important here to differentiate if we have a focal bulge, an area of focal bulge, whether this area of bulge is due to dry eye disease or due to ocular surface or due to ectasia. As we all know, if the differential diagnosis of irregular astigmatism or irregular surface on the topography could be due to ocular surface disease, or it could be due to corneal pathology, or could be a real ectatic corneal disease. And this, I will be focusing on the how to differentiate ocular surface disease from the ectatic pathologies, because these irregularities can lead to light scattering, will increase the higher order aberrations, it will lead to image distortion, and all this will affect the quality of vision. So the next step when evaluating a corneal topography is to look at the posterior surface. If we see this area, the upper scans, if we look at the posterior surface, we can find that the posterior surface is completely normal, while in the lower scans, we can find that there is a corresponding area of posterior bulge, which indicate that the lower scan could be due to ectatic disease, while the upper surface are due, the upper scans are due to ocular surface disease. And also, if you look at the area of irregularities, we can find here in the upper scan that it's ill-defined. Also, it's reaching almost to the tip of the scans, while in the lower one, it's more focally and more rounded and not reaching to the periphery. And this is another clue how to differentiate whether this is due to dry eye disease or to ectatic disease. Another very important tool nowadays in differentiating these abnormalities is the use of the epithelial mapping. First, we need to know what are the normal epithelial thickness in order to study the epithelial mapping. As we all know that the lower half of the epithelium usually thicker than the upper half, and also we need to look at the color scales because it's completely the opposite of what we used to understand from the corneal tomographies, where the blue colors, the quiet colors reflects a thicker cornea, while in the epithelial mapping, the blue colors reflect a thinner epithelium, and vice versa. When we see the red colors, it reflects a thicker epithelium rather than a thin cornea. So we need to keep these in mind when looking at the scans. So if we face a patient with this area of focal bulge, if we go to the epithelial mapping, what we can see that there is epithelial modeling in areas where the eye is dry. And this is, if we look at the total thickness of the cornea, it will not help us anymore. But if we look at the epithelial mapping, we can find that there is areas of epithelial hyperplasia, as seen here, that the epithelium is much thicker. And if we plot this against the standard coloring, we can find how thick is this area in the epithelium. And this is usually in the areas in mild dry eye disease. While in cases of ectatic corneal disease, we usually see that the areas in the area of the bulge are usually thinner. The epithelium will be seen thinner. So this is another important way to differentiate these abnormalities on the that we usually face or see on tomography machine. And the nice thing about these epithelial changes that they are reversible once the eye is treated with lubricants and all modalities of treatment and dry eye resolved. These epithelial hyperplasia usually returns back to normal, but this takes usually a few months. In severe dry eye, the picture is completely different, where we get a thinner epithelium. The epithelium gets thinner and thinner in a very severe advanced stage of dry eye. And this brings out a lot of reports to classify dry eye disease based on epithelial mapping, where in mild dry eye disease, we can find areas of epithelial hyperplasia in the lower part of the cornea. If we move to a more severe dry eye disease, we will get epithelial irregularities. And in severe dry eye disease, we can find that there is a thinning of the epithelium. If we look at the other parameters, the effect of dry eye disease on other parameters, there are a lot of studies found that there is good repeated measurements and excellent agreement for a lot of measurements, especially the central corneal thickness and other parameters like white to white and other areas. Usually these measurements are not affected by dry eye disease. And if we look at the corneal aberrations, blood studies also find that there will be increase in the aberrations in dry eye patients. So to conclude, dry eye disease is an important cause of corneal irregularities, even in asymptomatic patients. Epithelial mapping is a very promising tool that can be used to differentiate such abnormalities. Thank you very much.
Thank you very much, Dr. Khalid. It's an amazing presentation. Actually, I learned a lot from it. And let's move to the third speaker, who is me. Okay, so shall I start immediately?
Yeah, please.
Yeah, you can.
Okay, thank you.
In spite of that, we have one question to Dr. Khalid. There was a staging, if Dr. Mazen allow, a staging of the dry eye depending on the corneal map. I think that the coloration, it was because you said the thinning and it was thickening. So I don't know whether you were depending on a
mild dry eye disease. At the early stages of the disease, there will be focal areas of thickening of epithelial hyperplasia, usually in the lower part of the cornea. If we move to a more moderate dry eye disease, then the epithelium will get more irregular, and you can find areas that are thicker, some areas are thinner. You get an irregular epithelium. And if we move to a more severe dry eye disease, this could lead to epithelial thinning. And this is what is suggested in the literature, actually. Maybe Dr. Mazen has a better answer than me.
Yeah, I agree with you, actually. And just for one comment for the color scale, actually, the color scale can be adjusted in the way that you would like it to be displayed in. So you may have it reversed, but actually,
it was adjusted in reverse. That's why I know that, but it was adjusted in reverse.
But the standard one is, as Dr. Khalid mentioned, is that the thinner will go to blue rather than hot. Okay, so let me start. I'm going now to talk very briefly about an entity or a disease that we usually miss during our clinical practice. And for sure, it has an impact on everything, including cataract surgery, refractive surgery, and the usual treatment of patients with dry eye disease. Now, we all know that there is plenty of manifestations of the ocular surface diseases, including this long list. But the four major and main categories are dry eye disease, neurotrophic keratopathy, meibomian gland dysfunction, and meibomitis-related keratoconjunctivitis, which I'm going to talk about now. Now, meibomitis-related conjunctivitis is a disease in the cornea characterized by scar with or without new vascularization. And this scar, this is the second criteria, this scar corresponds to the portion of the lid that the meibomitis is most severe. So the patient usually has meibomitis, but in the area where the meibomitis is most severe, this pathology will happen on the cornea. As we see here, on the left side, a small portion, while on the right side, almost the whole cornea. Now, this pathology may range from very faint scars maybe with some vascularization or without vascularization into very profound melting of the cornea and even perforation. So it is just related to meibomitis. There are two types of this disease, the flectinular type and the non-flectinular type. The flectinular type ranges from mild, as you see, to severe. And it is characterized by nodules on the cornea, very similar to Salzmann, but associated with vascularization. The non-flectinular type is also characterized by scar or scarring of the cornea with or without vascularization, but there are no nodules. But the whole corneal surface is compromised. In a very famous study regarding this disease, there were two groups, the normal group and the diseased group, a comparison between these two groups. In the normal group, the P. acnes were isolated in almost a quarter of the normal group. And the rest, there was no pathogen detected. On the other hand, in the diseased group, the P. acnes were isolated in 60% of the patients, followed by aureus and followed by epidermidis, while no pathogen was detected in a quarter of the diseased group, which means that the P. acnes should be the first pathogen to think of when we see such a problem. And this leads us to the treatment of this disease. We can use topical, and we must use systemic at the same time, including one or a combination of more than one of the following medications: the cephalosporins, the sub-antimicrobial doses of tetracyclines, and sub-antimicrobial doses of macrolides. So we have to use systemic and we have to use topical whenever available. So to take a take-home message, we have to keep the diagnosis of the mebomitis-related keratoconjunctivitis in mind, and we have to detect faint scars, because sometimes faint scars are not because of herpes virus, as we always say that, okay, very faint superficial scar, maybe the patient had previous herpes virus. No, maybe the patient has mebomitis-related conjunctivitis, keratoconjunctivitis. And this disease is very, very aggressive. So we have to treat it aggressively. And thank you very much. I'm on time.
Thank you very much, Dr. Mazen.
Okay, thank you. I'm going to stop sharing now. All right. Dr. Safwan, would you please introduce the second speaker?
Yes, just let me open. I think that Dr. Nancy. So the neurotrophic keratopathy.
أمل الوريقات.
sorry. أمال sorry متأسف. دكتورة أمال الوريقات.
وريكات.
Yeah, دكتورة أمال وريقات. دكتورة أمال, please. Stage for you.
Good afternoon, everyone. Thank you, Doctor, for your kind introduction. And it's always an honor to be among this great group. So today I'm going to talk about neurotrophic keratopathy. Is my screen, can you see the screen now?
Yes, we can see your screen very well.
Okay. So my name is Amal Lourikat. I'm a corneal and refractive surgeon from Jordan. I have no financial interests. So all of us might encounter this kind of corneal ulcers, and it is always, when you see this, you know that this patient will stay a lot, and you will have a lot of visits, and it will be a long journey in treating such types of corneal ulcers. So as we all know, neurotrophic keratitis, the hallmark is decreased corneal sensation, decreased or no corneal sensation. There are many causes. On top of those comes the herpetic corneal disease, as we all know, the herpes simplex and herpes zoster virus. Any cause of damage to the fifth cranial nerve, history of LASIK, ocular surgeries, any history of contact lens wear, systemic diseases, chronic topical anesthetics or NSAID abuse, some corneal dystrophies, limbal stem cell deficiency. This is a very long list. So the severity of the neurotrophic keratopathy can be classified according to the Mackey classification. So the mild case, when we have an no epithelial defect, but we have a mild punctate keratitis. The moderate is when we have an epithelial defect, but there is no stromal involvement. And then we have the severe stage where we have a corneal ulcer, and if it's not treated well, it will end with scarring or with perforation. So this is a vicious circle. It starts with impairment of the trigeminal reflexes and the epithelial alteration, impaired healing, decreased tear formation, and then spontaneous corneal epithelial breakdown. There are many ways to classify or to quantify the amount of the decreased corneal sensation. First of all, you should instruct a no-touch visit. Sometimes we have a technician as a first encounter with the patient, so we should always instruct them when we have a case like this that we should not have any topical anesthetics applied on the eye, because this will affect the testing of the corneal sensitivity. There are many ways. We have all the qualitative ways, the cotton swab or WISP. Some doctors use the dental floss, and we can use a piece of tissue, and the corneal sensation will be described as decreased or absent or intact. We have the Couché-Bonnet test, which is a quantitative way. It has a thread and with a particular length, and we can quantify the degree of the corneal sensation according to the length of that thread. This is not available in every clinic. I used to have this during my fellowship, but it is not always available. The other comorbidities that need to be addressed and that might make the diagnosis difficult should be all addressed: dry eye, blepharitis, exposure, keratopathy, topical drug toxicity, mild chemical injury, contact lens related disorders. Those might interfere and may make the treatment even difficult. So as always, we start with the ABCs. We need to add significant lubrication and remove any offending agent. Any preservative drops should be stopped, and we should always review the bag of the medications, because sometimes you might be amazed with what the patient has, and that sometimes the patient will not tell you about all his drops. So always there is a surprise in the patient bag of medication. Start the antimicrobial as a prophylactic, and if there is a degree of inflammation, we can add topical steroids, we can add topical cyclosporine or doxycycline. So the treatment array is long and starts from the conservative measures and ends with the corneal neurotization. A few words about the SNED regimen. It is not available in my region, but there is a lot of talks about it. It is the first recombinant human nerve growth factor, applied 6 times daily for 6 to 8 weeks course. And the mechanism is the corneal innervation. It stimulates the regeneration of and the survival of the sensory nerves. There was a study about the efficacy of this SNED regimen. There was 2 big studies, one in the European and one is the US study. And they concluded that the medication is effective in at least 55% of the patients by week 4 and up to 70% of the patients by week 8. The side effects were minimal. 16% of the patient has an eye pain following the installation. Less than 1% have corneal deposits, foreign body sensation, and increased tearing. So we should have a plan always when we are dealing with a patient with a neurotrophic keratopathy, and we should classify according to the severity, and then we will look at all the options that are available. So the autologous serum tears, it is usually used as a preservative-free drop, and it contains the growth factors. It is beneficial in neurotrophic keratopathy and also in persistent epithelial defects. There is risk of infection, so it should be used with an antibiotic. I will not go over the way of preparation, and it can be used with 25% concentration, 50, 75, or up to 100%. It is divided into many drops, and it should be freezed, and then you can instruct the patient to do each vial and use it for 2 to 3 days. We do prepare those in our hospital. The amniotic membrane, there are many forms of the amniotic membrane, as you all know. It is composed of a thick basement membrane and avascular stroma, and it has all the growth factors, the protease inhibitors, and it acts as a substrate for the epithelial cell migration. There are many forms. There is the fresh frozen, the freeze dried. Then we have the Procera, which is very nice, but the cost is the main issue with this. And we do the freshly prepared amniotic membrane at our hospital. So we actually prepare the amniotic membrane from placentas after cesarean section birth, and after consenting the mothers and making sure that those are negative for hepatitis and HIV. This is a small video showing how we prepare and how we retrieve the tissue. This is the appearance of the tissue after cleaning, and then we store it for 14 days. And we can use it up to 14 days. We can use it up in a single or a multiple patterns, and stroma up or stroma down according, to the indication. We can use contact lenses, bandage contact lens that will promote the epithelial healing, or sometimes the scleral contact lenses that act as or provides a microenvironment for the ocular surface. Then also we should address all the issues, any problem with the lids, exposure, botulinum toxin, tarsorrhaphy, whether temporary or permanent, sometimes even glue, cyanoacrylate glue to tape, the eyelids for 10 days might help. So those are all the options. And then finally, we have the corneal neurotization. We don't perform this at our hospital. It is an endoscopic procedure, ipsilateral or contralateral, and we dissect the supraorbital nerve branches and insert it into the subconjunctival space. In cases of severe thinning or perforation, we have many options. It's cyanoacrylate glue, multi-layered amniotic membrane. We can also use tectonic or lamellar keratoplasty or penetrating keratoplasty. So in conclusion, neurotrophic keratopathy can lead to a devastating outcome if not controlled early. We should always create a good microenvironment for the healing, and it is a combination of things: removing the offending agents, improving the tear surface and tear film, topical, and then surgical options are all important. And thank you so much.
Thank you, Dr. Amal, for the very comprehensive and very nice presentation.
Thank you.
Would you like to, dear panelists, would you like to stop for 2 minutes, because we have good time? 2 minutes before we move?
I don't think we have good time, really. Still, we are running like 5 minutes delayed.
Okay, so let's move to the second speaker, Dr. Ahmed Assaf from Egypt. Dr. Ahmed, please.
Thank you very much, Dr. Mazen. Let me share my screen. I hope you can see my slides right now.
Yes. Your slides very clear.
Okay. So I'm charged now to talk to you about the impact of dry eye on IOL calculation. First of all, I would like to thank Dr. Mazen Sinjab for his kind invitation, as well as Dr. Safwan Abayati to share in this very prestigious meeting, and hope to see you in reality very soon. So let's start my presentation right now. As you know, that the refractive surfaces of the eye includes the precorneal tear film, cornea, crystalline lens, and vitreous. The precorneal tear film is the greatest refractive power, and it is the most important refractive media of the eye. And dry eye produce tear film irregularities and optical power changes along the corneal surfaces. And as you know, that the corneal power is a key component in any biometric formula, as it determines the power of the spherical IOL. So keratometers rely on good reflections or mirrors on the corneal surface, and unstable tear film will produce irregularities of those mirrors, and this will compromise the biometry or compromise the measurement of the corneal power with 1-to-1 ratio. 1 diopter error in measurement of the cornea reading on the corneal surface will result in 1 diopter of postoperative refraction error. And the same applies to optical biometry. It has the same principles as the all optical biometers shed LED lights on the corneal surface, and the camera seeks the brightest spots of these reflections. And the distance between these reflections is determined the corneal radius, and hence we can calculate the corneal power. In dry eye disease, the camera cannot identify those brightest spots, and this will result in error in measurement of the corneal radius, and of course, error in measurement of the corneal power. In one study, it shows that there is increased variability of the hyperosmolar, of the K readings in hyperosmolar eyes compared to the normal eyes. As you can see, this is in this study, the hyperosmolar eyes in blue, and this is the normal eyes in red. There is increased variability in the K readings in the same eye between two visits more than 0.5 diopters in the hyperosmolar eyes, significantly higher compared to the normal eyes. And this variability were up to 3.75 diopters in the same eye between two successive visits. And this is, of course, one of the leading causes of refractive surprise after cataract surgery. And this results in less repeatability and reliability of the measurement of the corneal power in cases of dry eye. And the error is not only in the mean K readings, but also regards the magnitude and the axis of the astigmatism, which is known as the vector astigmatism. And the vector astigmatism difference was more than 1 diopter in 17% of the hyperosmolar eyes in blue, as you can see here, compared to the normal eyes, only 2% in the normal eyes in red. So this results in higher incidence of post-residual refractive astigmatism in cases of toric IOL implantation. Again, there is another study regards the patients, the cataract patients. Cataract patients are at high risk to get a dry eye because of the age, because of the hormonal changes, some medications like the antihypertensive drugs, dietary factors, omega-3 fatty acid deficiency. In one study, it shows that patients coming for biometry prior to cataract surgery, 77% of these patients have positive staining on the ocular surface of any type, and 63% of these patients had tear breakup time less than 5 seconds. And the most astonishing fact here that these patients were asymptomatic. They didn't complain of dry eye symptoms. And this was confirmed by another blepharitis study, which showed that around 59% of these patients were having blepharitis of any kind, mainly posterior blepharitis, and 61% of these patients had breakup time less than 7 seconds. And again, those patients were asymptomatic. 100 patients, 200 eyes were included in this study, and none of these patients were complaining of dry eye. Why these patients do not complain of dry eye, it's not clear yet, but probably the symptoms of dry eye, like foreign body sensation, irritation, dryness, sense of itching, irritation, are masked by the neurotrophic component of dry eye. And of course, the cataract will mask the fluctuation of the vision, which is another chief complaint of dry eye disease. So what? We have to suspect dry eye in every cataract patient, look for signs of dry eye in every cataract patient. Don't rely on symptoms of dry eye, and treat dry eye aggressively before IOL calculation. As you can see, this is suspect dry eye, especially if there is discrepancy between the K reading measurements between different devices. You can see here the K reading in the corneal topography is almost 1 diopter, while in the IOL mask is 1.67 diopter. As you can see, again, there is difference in the axis of the corneal cylinder of more than 10 degrees, which is clinically significant. Of course, it will have a great impact on toric IOL power planning and calculations, of course. So we have to suspect the dry eye if there is discrepancy between the K readings. You can look for dry eye signs for every cataract patient, especially look at the corneal Myers, just for subtle changes of the corneal Myers. Look for the lid for meibomian gland dysfunction, do some staining, lissamine green stain or fluorescein staining, or look at the meniscus, tear meniscus height, or if you have the tear film analysis, you will have a more comprehensive data on the ocular surface and the quality of the tear film of those patients. Please do not rely on corneal tomography. Corneal tomography is less sensitive to detect dry eye compared to the corneal topography. Topographies are based on reflections, and that's what we are looking for. We are looking for reflections on the corneal surface, not the thickness of the corneal surface, as in tomography. So please rely on topography because it's more sensitive to detect subtle changes on the ocular surface compared to the tomography. And now, treat before any preoperative measurements. We have a myriad of options to treat those patients, like artificial tears, the short courses of topical steroids, topical cyclosporin, systemic tetracycline, IPL, punctal occlusions, mechanical exfoliation. We have a lot of options to employ for our patients to have optimized ocular surface before taking the measurements. This is another example. One of my patients have been before and after treatment of dry eye for 4 weeks. You can see a change in the magnitude of the astigmatism and the axis of astigmatism, and of course it would have an impact on my surgical planning for toric IOL implantation. Please do not instill artificial tears prior to biometry, because artificial tears will increase the variability of the K readings before biometry, and this effect extends from 30 seconds after installation of the artificial tears and 2 minutes after installation of the artificial tears. And this applies for the low viscosity artificial tears and high viscosity artificial tears. And as you can see, there is no specific pattern. Sometimes the K reading is increasing, sometimes the K reading is decreasing, so that you cannot even predict how much change it will occur after installation of the artificial tears before taking the K readings. And this effect is extended up to 5 minutes before, until the K readings goes back to those basic readings before installation of the artificial eye drops. And in some literature, it said it's extended more than 5 or maybe 10 or 15 minutes after installation of the artificial eye drops. So please make sure that before taking any biometry measurements or any K reading measurements, that the patient did not install artificial eye drops or even anti-glaucoma medications, eye drops, at least 10 minutes prior to biometry measurements. So to summarize, dry eye disease is a common in cataract age group. Most of these patients are asymptomatic. It must be suspected in all cataract patients. It significantly influences the K reading measurement. And of course, it affects the power calculation and the surgical planning in cases of toric IOL, and should be addressed prior to biometry, not before the cataract surgery, prior to any measurement on the corneal surface. Thank you very much for your attention.
Thank you very much, Dr. Ahmed.
As usual, very nice slides, very nice presentation.
Comprehensive, very important, comprehensive, very interested.
Thank you very much. Thank you very much.
الآن ختامها مسك دكتور أشرف. Dr. Safwan, would you please introduce Dr. Ashraf?
So Dr. Ashraf, he will give us. Dr. Ashraf, he's with us.
Yeah.
Dr. Ashraf. Yeah. So
He
impact
us,
of in treatment of patient with the glaucoma. Yes, Dr. Ashraf.
Thank you, Dr. Safwan, Dr. Mazen, for the invitation. I'm not a glaucoma specialist, but I see a lot of OSD in patients with glaucoma.
Yeah.
So I have no financial disclosure about my presentation, but these are my financial disclosures.
We cannot see your screen. Would you please share?
Okay.
Maybe Dr. Ahmed is not stop sharing. Dr. Ahmed Assaf.
Ahmed, would you please stop sharing?
I already stopped my share my screen. I don't share my screen.
Okay.
It's okay now?
Yeah.
Yes, we can see.
Okay. So I have no financial disclosure, but these are my financial disclosure. As we all know, that glaucoma is a chronic progressive optic neuropathy and most significant risk factor for developing glaucoma, and it is progression of the elevated intraocular pressure. So this means that topical intraocular lowering eye drops are the first line of therapy for glaucoma, and most patients requiring treatment throughout their lives. And also, we are known that is a leading cause of visual impairment. So the disease is characterized by progressive alteration in the optic nerve. So according to Kegley and Broman, there will be 79.6 million people around 2020 all over the world. So if we look we are going to find that ocular surface disease and hyperemia are the most common adverse events of topical ocular medication because of the preservative, while active components may cause allergic reaction or irritation. Preservative, which are intended to prevent the bacterial growth, are more toxic for the eye. So all over the world now, most recent glaucoma medications no longer contain preservative. Despite this, local tolerability may still impact treatment compliance and patient quality. But the etiology seems to be multifactorial and is influenced by age, ethnicity, sex of the patient, and may be associated with other disorders of the anterior segment, such as blepharitis, allergies, and dry eye. So the OSD is also linked to the chronic use of ocular intraocular pressure lowering therapies. And this is how we see most of the glaucoma, long glaucoma chronic patients on the slit lamp. The clinical presentation includes ocular dryness, irritation, burning, lacrimation, foreign body sensation, red eye, and blurred vision. And Buffy et al. Have already demonstrated that the tear film and the ocular surface are altered in patients using anti-glaucomatous medication. And it is also known that both active principle of the ocular hypotensive eye drops and the preservative used, usually the benzene chlorine chloride, which is the most important, can cause or aggravate the changes in the ocular surface. And Stewart also showed that in the OSD in glaucoma patients, 42% nearly have this OSD, and this percentage appear to increase when the number of the glaucoma drugs prescribed more and more, from 1 drug to 2, 3 per day. So this will aggravate the OSD. And also the very important, it's not just the OSD, it's also the quality of life. Numerous studies in the literature have shown that the presence of OSD in patients with glaucoma affects the patient quality of life and may influence therapeutic appeal. If he found himself, he cannot put the drug, he's going to stop the drug because he found that his quality of life is interrupted. In this table, comparing between the control group and the glaucoma group, you can see how is the keratitis and the conjunctival hyperemia and the break-up time is in the control group less than in the glaucoma group. And also the keratograph analysis between the glaucoma and the control, how the tear meniscus and the redness and the meibonography and the break-up time are more or less and is aggravated in the glaucoma group. You can see it here in the tear meniscus, how you can see the tear meniscus well seen in the control group, and in the glaucoma group, how you lost the tear meniscus. And also how you see the bulbar redness in the glaucoma, and this is the control group, how it is better. And also you can see the difference between pre-treatment and post-treatment. In the upper part is the pre-treatment, and the eye looks perfect in the lower groups. And this is the scaling of the Möbius scale, which is a very important. It ranges from 0 degree to degree 4, and it depends on 0% loss up to 75% loss of the meibomian gland, and you can see how it looks in the pictures. And this is compared between also a control group and the glaucoma group. The meibomian gland dysfunction is a major cause of dry eye. It's important to evaluate the myography to establish the correction between the meibomian gland loss and the OSD. And you see here how it is full number of the meibomian gland, and here are loss of the meibomian gland in cases of chronic glaucoma patients. And also in this table, you can see how a differentiation between the pre-treatment and the post-treatment in the best corrective visual acuity in the right and left, and you see how the difference is more improved post-treatment, and also the bulbar redness and the fluorescein, how it is improved in the treatment is more, and in the post-treatment is totally improved. So most of the studies found that the patients with glaucoma had a higher prevalence of OSD criteria than the control group, including worsening of the conjunctival hyperemia and all the symptoms like the bulbar redness and the tear break and the meniscus height. And the glaucoma affect millions around the world, and topical glaucoma drugs may impact negatively on the patient ocular surface and symptoms. And very important to highlight this for the glaucoma experts, they must take care of the OSD beside to treat your glaucoma patients. And the preservative drug, it is very important. Indeed, it's unfortunately that some countries does not have the preservative-free medication of glaucoma, but it is very mandatory to use. So my home-take message, as a glaucoma is a chronic and sight-threatening disease, glaucoma treatment demands lifetime management and strict compliance. So intensive ocular surface treatment of glaucoma patients under topical treatment may improve clinical parameters, symptoms, including IOP. Since the preservative has been shown to harm the ocular surface, avoiding or minimizing the preservative exposure may result in further improvement of ocular surface. But all the studies nowadays shown that the detailed characterization of the OSD related to glaucoma eye drops and the positive impact on the comprehensive ocular surface, raising concerns and important awareness both in the glaucoma and the ocular surface practices. Thank you so much for listening.
Thank you, Dr. Ashraf. It was a very interesting lecture that showed us how much that as a preservative material that we are using with the patients with the, having the glaucoma can affect the ocular surface disease. And in my question is that the issues is that when we are discovering patients with a glaucoma that having already existing ocular surface disease, you can imagine how they are suffering from adding any anti-glaucoma drops. And that's why in those patients that they are presenting with already with a grade 1 or grade 2 dry eye disease, I'm starting always with the preservative free. So great thanks for you, and the talk now to Dr. Mazen to finish the session.
Thank you very much, Dr. Safwan. Thank you, Dr. Ashraf, for the nice conclusion of the session. I'd like to thank all the speakers. It was a great session, actually, about ocular surface disease, updates in diagnosis and treatment. Thank you all. Thanks for the audience for being with us. And we hope to see you physically in the future.
Inshallah.
Inshallah.
Thank you. Thank you.
Goodbye.